Good morning, everyone. Thank you for joining this morning for our monthly case discussion series. We have a wonderful speaker today, so many people's mentor, and Dr. Cataland. He has been in the field so many years and has been a big advocate of classical hematology. And so he did his residency and medical school at Ohio State, and then he did his fellowship at the University of Chicago, and then he's been serving at the Division of Hematology and as a director of benign hematology at Ohio State. And we will get started. So the first case that we will go, this is a 30-year-old female patient with a history of preeclampsia, presented to emergency room with headache and was found to have blood pressure of 180 over 120 with the hemoglobin of 5 gram, MCV of 115 and platelet count of 45,000, in addition to low haptoglobin with undetectable haptoglobin, LDH of 800, retic count was 12% with the indirect bilirubin of 2.5. His coag lab, including PT, PTTD, dimer fibrinogen, were all unremarkable, and peripheral smear showed significant schistocytes, as you can see on the slide here. So the first question that we will ask, what is your initial approach for suspected TTP and possible etiologies for TTP, Dr. Cataland?
Very good. Thank you, Taha. So I think this is a perfect slide because this is a classic TMA presentation. It's not a classic TTP presentation, but I think it's important to think about these terms and how we use them and what they really mean. And I think the first is this thrombotic microangiopathy. In the classic sense, it's used to describe a pathological finding on a biopsy, usually a kidney biopsy. And it's microthrombotic disease, so thrombosis in the smallest vessels, the arterioles. But we also use it clinically to describe what you just see here, which is fragmented cells, thrombocytopenia without a clear explanation. And that slide right there should really trigger the differential diagnosis of a thrombotic microangiopathy. And as you can see here, this is a description I used from Maurice Scully, my friend, showing you the different possibilities. And there are a lot of things from the very rare to the very common. Obviously, we're going to talk about TTP, the atypical hemolytic uremic syndrome, or what we now describe it as, refer to it as a complement-mediated TMA. DIC can do this. Drug-induced causes of these TMA can occur. Metastatic cancer will do this. Autoimmune disorders will mimic these conditions. A lot of pregnancy issues, preeclampsia, infections, and malignant hypertension is a very common cause. So that slide that you showed, and I'll go back just a second, that slide should trigger the idea that this is a TMA, but I tell our trainees and our faculty, the TMA is not a diagnosis, it's a finding. Then you've got to sort of narrow it down. So how I would approach this patient, the very first thing I would say is there are some things that aren't classic for TTP. We'll talk about this in an upcoming slide where typically the platelet count is less than 30,000. Typically there's renal injury, but not renal failure. There's obviously exceptions to the rule, and a patient with a history of TTP is known to present earlier because they know their own diagnosis, their history, and they'll show up earlier. So on the very surface, when I see hypertension, I see an elevated MCV, which raises the question of maybe some hematologic issue, a bone marrow issue, thrombocytopenia. And something also to remember, it's kind of it's common, but it's a zebra, is B12 deficiency. And a megaloblastic anemia can give you, obviously, anemia, an increased MCV. You shouldn't be reticking like this, but severe B12 deficiency will give you pancytopenia, and the intramedullary hemolysis from these fragile macrocytic cells, megaloblastic cells, will look just like this with a very high LDH. So you could tell me the B12 level here was 50, and I would say that makes perfect sense here. But those are all things that you want to think about. A quick glance at this says that platelet count isn't as low as you'd expect. Hypertension's in the picture. There's clearly hemolysis. The coags are normal. This isn't DIC, but I would be thinking about, okay, is this a hypertension? Is there a long-standing history of hypertension, malignant hypertension? Is this a complement-mediated disorder? There's an association of preeclampsia and some pregnancy-related issues with complement genetic variants as well. They can be driven by those as well. So I think the differential is wide open here. And you wouldn't necessarily jump right in with plasma exchange, although you're going to think about it. This is a simple way of looking at, and these are old data. You can see some of it's ours, some of it goes back to 2004 and Tom Rafe at the University of Iowa. But the real quick way to look at a TMA presentation and your likelihood of seeing ADAMTS13 deficiency is really the platelet count and the serum creatinine. I think you'll find if you look at the plasma score carefully, what really drives that score is the thrombocytopenia, the renal injury, but not failure, and the lack of another clear explanation. A lot of those factors in the plasma score exactly talk about that. So the first thing I'll do with our trainees and myself in my mind is look at the platelet count. If you look at these historical data from everybody and the patients who were eventually found to have severely deficient ADAMTS13 activity, and these are very divergent groups. You're not seeing things at 10, 12, 17%. So whatever threshold you're using, it doesn't really matter. But in the patients that were found to be severely deficient, they had clearly lower platelet counts and lesser degrees of renal injury. If you look at the patients who were eventually found to have measurable or non-deficient ADAMTS13 activity, again, the opposite, the higher platelet count, greater degrees of renal injury and renal failure. So the plasma score is quite good, helps to sort of organize your thoughts and how you approach this. But what really drives this is the platelet count, the creatinine, and a clinical assessment of other causes of that thrombocytopenia.
Yeah, the question all comes to that point, right? So let's say the plasma score is concerning, or French score is concerning. You be considering doing the plex while waiting for ADAMTS13?
Yeah, that's an excellent point. That's really what the plasmic score is for. It predicts the likelihood of severely deficient ADAMTS13 activity. So technically that is TTP, but it really doesn't predict TTP. It predicts severe deficiency. And obviously TTP is the TMA that's driven by severely deficient ADAMTS13 activity. So that's where you want to do plasma exchange. So you're removing an antibody, adding back protease. So a plasmic score or a quick platelet and creatinine evaluation, that's what's going to tell you in 3 or 4 minutes, do I need to do plasma exchange tonight or do I not? And I think what you'll find is the patient who has creatinine of 10, has a long-standing history of hypertension, a platelet count of 80, that's going to have a lower plasma score. You have other potential explanations. In those situations, you might just do blood pressure control and monitor the hemolysis and look for other etiologies. So you don't want to not do plasma exchange when it's clinically necessary, but you also have to be careful putting in a deep line, exposing someone to donor plasma. You can have reactions to that as well. So you really just want to know who needs plasma exchange in that first 24 to 48 hours and who doesn't while you await your ADAMTS13 result. This plasma score is quite helpful, but it's not a replacement for that ADAMTS13 testing.
Okay, great. So let's say the patient got the exchanged, right? And ADAMTS the following day came back 5% on antibody is not going to come back right after, but antibody eventually came back as a 30 Bethesda unit. So you confirm the diagnosis of TTP. What will be your treatment approach for treatment naive patients?
Yep, that's a very good question. And I think also the other thing you're going to use to confirm this diagnosis is the response to plasma exchange therapy. So after that first exchange, you're not going to fix things. These are typically IgG antibodies, so wildly dispersed in the extravascular space. So they're not going to get better with one exchange, but they should improve. And you're going to be physically removing LDH because you're taking out patient plasma and putting in donor plasma, which should have normal or non-elevated levels. So what you're looking for is a decrease in the LDH and a stabilization, maybe an increase in the platelet count. So that's also going to be a clue that this is likely a TTP case. But when we talk about treating TTP, what are we trying to do? And kind of to make it simple, there's some simple milestones that we use here. And the first is we want to sort of affect or induce a clinical response of the disease. Obviously, this disease is driven by the formation of microthrombi, and it's the thrombocytopenia that we see, the hemolysis markers, and the LGH is a marker more of tissue injury than hemolysis, but it will take care of both. But when we see those being abnormal, when they are corrected and normal, we use it as a surrogate marker for no new ongoing microthrombotic disease being formed. So the first goal we have is to correct the platelet count and normalize or have a normal LDH, which along the way should also help with end organ recovery. Both short term, what we're talking about, mental status changes, kidney injury, but also some longer term issues that we might talk about later. So I tell patients the first thing we want to do is correct these defects with the plasma exchange, and we'll talk about immune suppressive therapy and other measures. The next important milestone, once you correct that platelet count, is the ability to, if you will, stop therapy and not have an early recurrence of your disease. This term exacerbation has now been formalized by the International Working Group, and it refers to the recurrence, and the terminology is important, so we all in the field are talking about the same thing. An exacerbation is a recurrence of TTP, or the need to restart plasma exchange within the first 30 days after stopping plasma exchange. And you'll see the new treatments, Caplacizumab and recombinant datum TS13, have evolved the change in our definitions to now be the need to restart plasma exchange within the first 30 days of stopping plasma exchange or the last anti-BWF therapy. And I'll show you why that's important when we talk about some Caplacizumab data. So this is a very real phenomenon. These are patients who have left the hospital, and within 2 weeks, they're more common to occur. And these are patients that have come back in the hospital, restart plasma exchange therapy, and it's a real problem. You're just as likely to have complications with an exacerbation than you are with the initial diagnosis and treatment. These terms were defined originally to separate what is a new distinct episode or a relapse from a continuation of the previous episode. So the achievement of a normal platelet count we refer to as a clinical response. If you get past this exacerbation time period and you don't have it, so 30 days after the last plasma exchange or anti-BDF treatment, and you stay in remission with a normal platelet count, we call that a clinical remission. After that point, if disease recurs, we refer to it as a relapse. An exacerbation is a continuation of the prior episode. So it's important that we use those terms sort of correctly so we're all talking about the same things. We've all kind of done that in the field. So this is the updated definition that I talked about. But it's important to understand why things happen and why things don't happen. And again, this is a significant, I've heard this referred to in different settings as a minor issue. This is not a drop in the platelet count on plasma exchange therapy. This is a recurrence of the disease, usually after they're out of the hospital and line has to go back in and plasma exchange restarted. Most commonly, it's going to occur in the first 2 weeks. And it makes sense why that happens. And I'll show you that in some upcoming slides. But again, this is a significant issue. It causes a lot of problems for patients as well as physicians when the patient has just gotten out of the hospital 1.5, 2 weeks earlier, and you're talking about putting them back in the hospital for another deep line and, of course, a plasma exchange.
Okay, yeah, very interesting new definitions. So, can you a little bit talk about what's the evidence for prednisone, rituximab, and caplacizumab for initial treatment, and what is this, disease relapse prevention role for each medication?
Very good question. So I think what you have to do is look at the available data and understand what endpoints we're talking about. And then you'll understand why things work and why they don't work. Now let's go to the first slide. Now it's going to sound funny, but there are very little data regarding steroids and their effect on the ADAM TS13 activity. They've been presumed to be effective going back to Dr. Bell's initial work, where a cohort of patients were treated with a TTP-like picture with just steroids. So the presumption is that they work by suppressing anti-ADAM TS13 antibody production, which then enables the recovery of the normal atom TS13 protease functional activity. But again, there are very few data that show this works. And this was a study we did, doesn't seem that long ago, but I guess it's been about 7 or 8 years ago, where we were comparing, doing some initial work with, in addition to plasma exchange, studying cyclosporin or prednisone as an adjunct to plasma exchange. We knew plasma exchange alone was not affecting exacerbations. We did this study to try to impact exacerbations because it has been and continued to be a significant issue. So if you look at the measures we did, so this is, and if you want to, you can ignore the cyclosporin. We can talk about it later if you want to. But in the blue line, you see the prednisone treated patients. And the top panel, you see the concentration of the anti-ADAM TS13 antibodies. And below, you have the ADAM TS13 activity. Now, it's important to focus on these time points. This is obviously pre-treatment. This is before the first plasma exchange, and everybody's got severely deficient ADAM TS13 activity. But week 1, 2, 3, and 4 refer to the 4 weeks. So this is covering the 30-day exacerbation time period after the last plasma exchange therapy. So what you've got is usually 7 to 10, 12 days that they're in the hospital. This is 5 to 7 days after they're discharged. So it's going to be usually at least 2 weeks from when they started their therapy. But what you can see is you're getting at least 1 to 2 and 3 weeks after discharge from the hospital before you start to see the majority of patients achieve ADAM TS13 activity over 20%. So it makes sense that in this window where exacerbations are more likely to occur, they're likely being driven by the failure to recover your ADAM TS13 activity. You just needed more time to do it. So the conclusion from this study was the steroids and cyclosporin were effective both in reducing antibody concentrations and improving the ADAM TS13 activity. Neither did it quick enough to improve the exacerbation rates, and that's what we saw in the study. There was no difference. Rituximab, obviously, you're all very familiar with rituximab. It's an anti-CD20 antibody, and it was first used in refractory TTP, eventually moved into upfront. We now use it as a preemptive therapy, but you've got to focus on what it's doing. And does it improve these exacerbations? And the honest answer is no, it doesn't. And if you will look at these data from Marie Scully, that'll make more sense to you. So in these data here, the rituximab was started within 1 to 3 days after the first plasma exchange procedure. So these day 8, 15, 22 are a bit different than the previous data I showed you. But again, if you look at the benchmark of 20%, we're talking 25 to 30 days until the majority of patients are now above a level of 20% that we think is protective. And that should explain to you why this is very effective at either preventing or delaying relapses of TTP, but not very good at preventing exacerbations. So although treatments have improved with steroids, rituximab, plasma exchange therapy, nothing has been shown to decrease or impact this exacerbation rate. Good data, but not you have to be careful what we're talking about. Again, exacerbation versus relapse. So these are data from the Titan study. So this is the first study, a randomized controlled study of caplacizumab compared to placebo. And I think most of you are familiar with caplacizumab. It's a small molecule or an antibody that binds to the A1 domain of VWF and prevents VWF platelet interactions. So it doesn't fix the disease. It doesn't alter the ADAM TS13 activity, but it blocks the downstream effects of not having physiologic sized VWF multimers. It prevents pathologic and physiologic platelet VWF interactions. So as you might expect, if you block the consumption, if you block formation of microthrombi, you've got a quicker time to a normal platelet count with caplacizumab compared to placebo. And that's a nice, clear, upfront endpoint. It's not that clinically exciting. It's not that clinically important. But what is important is the exacerbation rates. And what you can see here is the marked reduction at 28% in placebo versus 8% in the caplacizumab treated patients. So you've got a marked reduction in these exacerbations. And if you think about it, it makes sense. Several hours after the first dose is given, you're blocking the downstream effects of the disease. So you may not have recovered your ADAMTS13 activity, but you can't form the microthrombotic disease that leads to the formation of, or leads to the development of an exacerbation. Now, when these data first came out, there was a little bit of misinterpretation of things. And this is why I said definitions are important. The message was Caplacizumab patients have an increased relapse rate, which is a bit misinterpretation, a bit of nonsense if you look at what really happened. So remember, in this study, the old definition of exacerbation was used: 30 days, recurrence within 30 days of the last plasma exchange procedure. But these patients, and I didn't show you the schema, these patients were treated with Caplacizumab during plasma exchange and for 30 days after. So this covered the exacerbation time period. So it's important to note that this drug really prevented exacerbations for the first time. But when the drug was stopped and they had not corrected the ADAMTS13 activity, you had recurrences of the disease. And you see 8 of these recurrences, 8 of the 11 that happened in the first year happened in the first 2 to 3 weeks that the protection of the Caplacizumab was taken away. So you really don't have an increase in true relapses. What you've got is the protection was taken away. They'd not recovered the ADAMTS13 activity. And now they were at risk as they were before for exacerbations. And if you look at the data more carefully, especially the placebo-treated patients who were clearly had exacerbations, right, in that first 30 days, they were driven by non-recovered ADAMTS13 activity. But if you look at the Caplacizumab-treated patients, very few exacerbations, but in the relapse where there were ADAMTS13 measurements available, you see these were driven by undetectable ADAMTS13 activity. So the disease process had not recovered yet. You took away the protection and they were at risk for exacerbation just like before. And just to show you the difference for what was learned from the phase 2 Titan study to the phase 3 Hercules study, essentially the same study, with the exception of, so one-to-one randomization, they got placebo or Caplacizumab, but they got an extension of up to 20 days of the Caplacizumab at the physician's discretion. And this was driven by the ADAMTS13 activity. So if someone did not get rituximab, they could add it. If it was started a bit later, maybe after hospital discharge, there was more time for it to have that effect. Again, 2 to 3 weeks for it to start to occur. So if you look at the data you saw here, essentially the same thing that you see in the Titan study. There's a marked reduction in these exacerbations or these early recurrences of TTP. And we can talk a little about later if you want to about refractory TTP. There were very few refractory TTP patients on this study, which is likely a function of any study where the very sickest patients may not get enrolled on any arm of the study. But the suggestion has always been that if you can block the downstream effects of TTP, this microthrombi, you should not experience, or the result, getting refractory TTP should not be a common event. I think that's exactly what we see.
Yeah, so then the question is going to rise: when would you avoid the Caplacizumab as an initial treatment, and when would you highly recommend?
Yeah, there's been sort of, and you'll see this in UpToDate, and recommendations are to only give it to the sickest patients. And I think that's a way of thinking about it if you're only going to think about refractory disease. And refractory disease it happens. I mean, we used to say the mortality of TTP 10 years ago was 10 to 15%. That true number is probably less than 5% now. It is a bad thing to see and a bad thing to deal with when you're refractory to immune suppressive therapy and plasma exchange, but it's relatively rare. I think the bigger issue with Caplacizumab is the protection from these early relapses or these exacerbations. So it'd be nice to give this to only people who are at risk of having refractory disease or people at greatest risk of having an exacerbation and not give it to anybody else because it's clearly expensive. The problem is we just don't know who's at greatest risk. So at our institution, and many institutions, it will be given to all patients unless you have a concern for bleeding. So we always have to talk about side effects, and you're interrupting the platelet VWF axis. You're interrupting the formation of microthrombotic disease. So if you will, what you're doing is inducing a form of von Willebrand disease. And that's not something great, but it's certainly better than the alternative of this massive prothrombotic state of TTP. So what you typically see in terms of side effects is predominantly bleeding. It's epistaxis, it's gingival bleeding, hematuria, heavier menstrual bleeding. But for the most part, these are very much controlled. You could have severe bleeding, but for the most part, these are controllable, manageable things, either with holding the dose or in cases where you're concerned, you can actually give von Willebrand factor, give these intermediate purity factor VIII concentrates or recombinant VWF, give them VF to sort of reverse the effect of the caplacizumab. So this is the safety and most of the side effects that you saw on the study were all related to bleeding. So the patients who don't get it are the patients with a concern for bleeding. So we had a patient come in a couple of weeks ago, has a thought to be a cerebrovascular accident with an area of hemorrhage and concern for post-hemorrhagic conversion. So that's somebody who doesn't get caplacizumab. We'll do rituximab, steroids, plasma exchange, but not do caplacizumab right off the bat, unless you absolutely need it for another clinical reason later. Again, it's that concern of bleeding.
Yeah, I think you did answer this question. Maybe a little bit on side question I should postulate
Yeah.
here. So what will be the timing of weaning off or taking the patient off caplacizumab? Let's say you started and you are seeing the platelet recovery, and you may be waiting for you may be looking for you may be waiting for the ADAM-TS results. Uh, uh, when would you start backing off? When would you start taking the patient off caplacizumab?
Yeah, and if you go strictly by the label, it'll be 28 days with an extension if non-recovering ADAM-TS13 activity. But I think that the better answer is what most experts in the field will do is use that ADAM-TS13 as a guide in the context of your clinical evaluation of the patient. So the best example is the patient that we had on study who had a bleeding complication. So she didn't have a life-threatening bleed. I refer to as a comfort-threatening bleed. She had massive epistaxis, and with towels for several hours, the bleeding wouldn't stop. We knew from our previous evaluation the week before, she was about 3 weeks out from discharge from the hospital in her last PEX procedure. So I knew she had recovered her ADAM-TS13 activity to about 23%. She was on study, so she was sort of mandated, if you will, for the 30-day course of caplacizumab. But we factor in the bleeding, the recovery of the ADAM-TS13 activity, and with that, it gave us the comfort to hold and reverse the effect of the caplacizumab, knowing that she's recovered the ADAM-TS13 activity. The main guide you're going to use, though, is the ADAM-TS13. And when you know the time frame to expect it, you expect it 2 to 3 weeks after the rituximab. So the question you're going to be asked clinically is, do I need to order another 30 days of caplacizumab? And the honest answer is most of the time you need is no, or you need just one additional week, but sometimes you're stuck having to get the full 30 days. But it's really the recovery of the ADAM-TS13 that tells you the safety of stopping caplacizumab. It's not an absolute. If someone's at 18%, if they were 0, 0, 6%, 18%, you got a pretty good idea the trend is upward. That's somebody I might stop after 30 days, even though they're not technically at 20%. So you kind of have to use your judgment, use your understanding of when improvement happens after the first dose of rituximab. And you can see the importance of giving the rituximab as early as possible to get them off caplacizumab if you're using it. So it's really the sooner you start it, the greater the sooner the recovery is going to be experienced in that patient.
Okay, great. So we can move to next question. So again, this is another question I think is important to discuss. What about the delayed normalization of ADAM-TS while on caplacizumab? There has been some reports from European colleagues.
Yeah, it's interesting. It's not real clear as to why this has happened. That's why you do studies so you understand things. Things aren't always as you expect them. But UK Group Marie Scully has reported a delayed normalization of the ADAM-TS13 activity. I believe there's similar data from the Japanese who reported something similar. But I think one we always have to understand that everybody's population isn't the same. There are now emerging data from our US TMA consortium that show there are sort of racial differences in responses to rituximab. Um, there are differences, it looks like, in subsequent course of rituximab. Your duration of response may be shorter with each course. I think, as with most treatments, when it first comes out, it's effective for everybody. Then we start to realize that any treatment, and rituximab is no different, is more or less effective in some population of patients. So I think this may relate to patient differences. Our populations here in the US are more Black than white, and it's a different sort of animal in terms of disease than you'll see in a European population, where their population is more of an Afro-Caribbean population. So a bit different. So you have to be careful. These data here that I'm showing you are from the Caplo 500 abstract that was presented at ASH this year by Paul Coppo. And this was a remarkable effort to address a lot of questions in TTP. And this was done by pulling in a lot of the investigators, all of the investigators from this voluntary international working group that's been together for about 10 years and led by Marie Scully. And everybody was asked to contribute their Capla-treated cases from their registry. And in really just around 6 months, he was able to get what is now over 1,000 cases of retrospective data of Caplacizumab-treated patients and a collection of historical controls. So there are limitations, obviously, with retrospective data, but the strength of it is the numbers that you can achieve. And this was done with no money, just a little bit of hard work and collaboration amongst the group. But if you look at the bottom, you kind of see, you sort of see on a larger scale what you got from the Titan and Hercules studies. Response rates, so again, that normal platelet count, really a manifestation of refractory disease, are better on caplacizumab. Marked reduction in the exacerbation rate, a reduction in this refractoriness, decreased number of plasma exchange, which is great. But here's also, if you look at the time to ADAM TS13 activity, over 20%. Now, again, this can be sampling error, frequency of sampling, and much of these issues may relate to more ADAM TS13 testing in people who are on caplacizumab where it wasn't done as reliably before. But you can see there was really no difference in the time of recovery of the ADAM TS13 activity. So I think the jury is still out on does this affect the recovery of the ADAM TS13 activity, or is there another reason for it? But there's conflicting data on this, so I think the best answer is it's more complicated than we think.
Okay. So then I mean, when would you be considering the refractoriness versus the exacerbation in terms of the terminology?
Yep, and I stuck this picture back here so of this slide so we can remember what we're talking about. Exacerbation is a recurrence of the disease, usually after they've left the hospital and the line is removed. Refractory TTP is sort of interesting. People will say it's not easy to define it, but you know it when you see it. Typically, it's somebody on plasma exchange therapy with immune suppressive therapy that over 3 days or 5 days fails to double the platelet count. You don't see an improvement in the LDH. But when you see someone with refractory disease, what you're typically seeing is a rising LDH, a platelet count that's not getting better, and ongoing signs of clinical and organ injury. That can be worse in kidney disease, but more commonly it's mental status changes. If you check troponin in these patients, they all leak troponin, but in a refractory patient, you're going to see a progressive rise in that troponin, which is indicative of cardiovascular injury, myocardial injury. And when patients die from TTP, they die from progressive microthrombotic disease. Typically, and most commonly, it's a cardiac death, not the epicardial vessels, but rather it's the microvascular involvement. So refractoriness is truly a less, and it's hard to judge how common it is, but I judge it in what I see clinically, what we see in our studies, and also the number of questions I get. I answer questions a lot of times on cases with email or cell phone calls. And I think in the last 5 years, there's a lot less difficulties with refractoriness than we had before. And if you think about it, the heart of the disease is microthrombotic disease. If you can block those interactions, you really shouldn't have refractory disease. Now, there are patients with what we say refractory, they're refractory to immune suppressive therapy. So there are patients now, when I've had them on caplacizumab for 2 and 3 months, who aren't responding to rituximab. and then other forms of immune suppressive therapy like cyclosporin. So we're truly refractory where people die on plasma exchange. I don't think we're going to see very often anymore. That's a horrible thing to see. You're sort of helpless. Um, the new version of refractory may be refractory to immune suppressive therapy, and you're having a hard time stopping caplacizumab safely. And many times you have to stop it before you've recovered the atom TS13 activity.
Is there some sort of magic number, like 3 weeks versus 4 weeks versus 5 weeks if they're not responding?
Now, you're truly refractory TTP. Again, I said it earlier, but it's hard to define. You'll know it when you see it. It's a scary thing. Usually, you're talking 2 or 3 days of a rising LDH and a platelet count not getting better and organ injury. So, and this is not typically going to go on for very long. Over several days, you're going to have progressive injury. The best way to describe it was scary and informative at the same time was if you go before caplacizumab, before you had caplacizumab, you had a drug called Archimix 1779, and it was the predecessor to the A1 domain blocking drugs. And this was a drug originally developed to block stent restenosis in cardiac disease. It was given as an IV infusion, same idea. It was we'll call it an aptamer, a slightly different molecule, but a small piece nucleic acid that blocked the interaction of platelet and BWF. And on the very earliest phase 1 study, we had a patient at Ohio State that was on the Archimix drug, on plasma exchange, steroids, rituximab, and despite that, had a platelet count that wouldn't go up, and the LDH that was slightly rising but never improving, sort of refractory disease. Because there were only 2 weeks of human data with the FDA, the drug had to be stopped after 14 days of treatment, which kind of frightened us. And the drug, when it was stopped, what you saw in the following 24 to 48 hours was a progressive rise in the troponin, cardiac arrhythmias, and then he eventually died, unfortunately. So what you see was the protection of the patient was there. Once that was removed because we were forced to, you saw the unprotected patient, a true refractory disease. And there are patients who, because of the amount or the titer or the avidity of the antibody, we weren't able to keep up with plasma exchange. We talked about twice-day plasma exchange, giving gram of Cytoxin, but the truly refractory cases, we were sort of helpless to fix.
Okay, interesting. So then some more practical questions. This comes on service. When would you recommend the anticoagulation during the plaques? When to consider red cell or platelet transfusion in acute settings? And how do you taper the steroid for
Yeah,
TTP?
it's a good question. So there's some great data from Katarina Pavensky from Canada, who really shows that these patients are at greater risk or equal risk to DVTs as other patients. So you can't get blinded by the thrombocytopenia that you saw initially and alter your clinical judgment of things that you know you need to do. So you still have to protect them from DVTs. You know, you may want to, if somebody has atrial fibrillation and needs systemic anticoagulation therapy, you might wait until they're over 30,000. But you also have to remember that 30,000 in somebody who's producing platelets is different than a 30,000 in an aplastic anemia patient who's not making platelets at all. So you have to use your clinical judgment and remember that this is a disease of platelet consumption and microthrombotic disease. It's a clotting disorder. It's not a bleeding disorder, and you have to be careful of that. You'll see this issue come up with platelet transfusions. And if you show me 100 institutions, I'll show you 99 different practices and how you do it. I've seen lines put in for 25, 30 years without platelet transfusions, and you don't see excess bleeding complications, assuming the line placement goes well. And I think that's because, again, this isn't an aplastic anemia patient where you're not making platelets. They're making them and then they're being consumed. So you have some platelet function. So are they required before a placement of a central line? No. If somebody says, I want to give platelets before I put the line in, that's fine. It's not unreasonable. The biggest danger in platelet transfusions in TTP is not necessarily, and this has gone back and forth in the literature, the biggest danger is that if you don't know what you're doing, meaning if you are just blindly transfusing platelets for a thrombocytopenic patient and you've not considered TTP as an etiology, it sort of highlights that you don't know what you're doing, meaning it highlights that you weren't really thinking about TTP. You were just blindly giving platelets. It wasn't the platelet count, that the platelet transfusion that was the problem, but it was the lack of recognition that this was TTP. So you didn't do plasma exchange. You just gave platelets. You'll see the report. There are some reports that say that giving platelets with plasma exchange is not an unsafe practice. But I think that just shows you you're treating the disease and you're giving platelets as an adjunct. So giving platelets by itself, is that dangerous? No, I don't think so. Most people will tell you no. But is delaying plasma exchange because you were just kind of knee-jerking giving platelets, that can be a bit dangerous. So it highlights that maybe you weren't focused on the true, differential diagnosis and what you should be worried about more than anything else.
How about the steroid tapering?
So it's a good question. I think I'll pull the next slide up. So I asked this question of my colleagues, and we talked about this already, right, with the rituximab.
Right.
And if you look back at the time to recover the platelet counts, I'm sorry, the ADAM-TS activity in the steroid-treated patients, it's really, and I should mention, these are patients, this was with plasma exchange. If you look at Marie Scully's data, these were also with steroids as well in nearly all patients. So I asked the question of my colleagues, do you really need steroids if you're giving somebody very early rituximab? Because you're really accomplishing the same thing. And I've had patients who have relapsed disease who have refused steroids. And I don't argue with them too much as long as we're giving them rituximab. So my practice with the tapering of the steroids is as quickly as you can and very quickly after you start the first dose of rituximab. So once you give that first dose of rituximab, you start the clock of 2 to 3 weeks to recovery of that ADAM-TS13 till it begins. So I'll usually taper steroids in the first 4 weeks or even sooner, and I get much more aggressive after we start the rituximab. And that begs the question, do you need steroids if you're giving somebody rituximab? And that's a good question that we still have to answer.
Okay. So how do you approach for TTP relapses?
So that's another good question, Taha. And again, I like to go back to if you know why you're doing something or not doing something, it makes more sense. So we looked at this a couple of years ago, more than a couple of years ago. This is work from Ming Jin when she was working in our lab. And we looked at the modeling that we were doing. So going back to 2005, we would monitor the ADAM-TS13 activity every 3 months. So the modeling you have here is what is the risk of relapse with a given ADAM-TS13 activity over the next 3 months. Then the next 3 months starts a new time block. And what you see on the left, and again, these are all patients in remission more than 3 months out from the last TTP episode. And what you see is the lower the ADAM-TS13 activity, the greater the probability of relapse over the next 3 months. But if you look carefully, this number is not so great, only 10% over the next 3 months. But when you break this down by age, what you see is the younger you are, the risk of relapse seems to be greater. So approaching 30, 40, and 50% in the next 3 months in the younger patients. This should tell you that the ADAM-TS13 activity is our strongest risk factor, but there are other factors involved, age, and some other things that may play into this as well. So we'll monitor patients every 3 months for the ADAM-TS13 activity. And when it starts to drop close to, when it's trending downward or below 20%, we'll talk about preemptive rituximab therapy. And that's really how the field has been going. It's the upfront use of rituximab, but the greatest impact has been based on data from Paul Koppel, you see here from the French group and Marie Scully's group, is the use of preemptive rituximab. So you're in remission treating the ADAM-TS13 deficiency. If you go back and look at these international working group definitions, we've accounted for these same phenomena. So there's clinical response, clinical relapse. There's now ADAM-TS13 remission, ADAM-TS13 partial remission. To account for those are patients that you might be doing additional immune suppressive therapy on. So in this case, these French data, they compare their preemptive therapy. So every 3 month monitoring when below 20%, for the most part, again, these are all retrospective data. But when below 20%, they would treat preemptive. And you can see a significant improvement in the relapse-free survival. These are historical data and retrospective look at it. So it's a bit tougher that way, but it's a rare disease and it's the best thing that you've got. So there's no question. I don't know if rituximab prevents relapse of TTP, but it certainly can delay it. So the disease has really moved in remission to preemptively treating them to prevent relapse of disease. And I think it's not perfect, but it's very realistic to say that we can prevent most relapses of TTP. The bigger issues now are the development of these long-term complications, a shortened survival in people with a history of TTP. And it seems to be that survival difference is driven by cardiovascular complications that occur in these patients that may be independent of the ADAMTS13 activity.
Okay, great. I think this is the last question before we will ask the audience to postulate their questions. What do you think about this recombinant ADAMTS13
Yeah, that's a
for?
good question. There are data that will be published very soon. It's been presented at the European Hematology Association, EHA, a couple of years ago. And the idea is, and this goes back to Fritz Schiffinger's work in the early 2000s, where you can overcome an inhibitor with a very large dose of ADAMTS13, either by overwhelming it, binding it, or chelating these inhibitors. And on the surface, it seems to be a reasonable approach and has led to actually two ongoing studies. One is the use of caplacizumab without plasma exchange, and an ongoing study of recombinant ADAMTS13 without plasma exchange. Both studies are similar in that the physicians have the option of adding plasma exchange if they feel clinically it's necessary. But the endpoints on both studies are the need to do that. And so far, they're very early on. Both are accruing well. And I think in the next 1 to 2 years, we're going to get an answer about this. And I think it's going to be an interesting answer that tells us plasma exchange may not be essential for the treatment of TTP in the future.
Yeah, very near future. Thank you,
Or
Dr.
needed. Yeah, it might not be needed anymore, which might be nice, right? To go from the less specific to the more specific treatment. So
Yeah, much, much less invasive. So I think we are done. We have some faculties and some fellows in the audiences. Please feel free to ask your questions.
Dr. Cataland, thanks for the great the talk.
thank you, man.
I learned a lot. I had some questions about it's always a little difficult for me prescribing Capla in a de novo TTP patient where we don't have levels back and we're needing to put in a line. And I wanted to know what your thought process is, when you don't have confirmation of the diagnosis. It's especially tricky when, for instance, it ends up being a lupus-related TMA and not immune-mediated TTP.
Yeah, it's a good
Do
question.
you have any experience with situations where Capla is given and ultimately the diagnosis of TTP is ruled out? Is there data that shows that there's a higher risk of bleeding, perhaps?
Yeah, some of the studies they've been able to look back and see the patients who didn't have ADAMTS13 deficiency, and it didn't seem to be increased, if you will, bleeding complications. I think that's an important point you're making. And I think there's a couple things you have to consider. I think the first is if you're is people will compare a dose or two of caplacizumab compared to a deep line in plasma exchange therapy. Is there really a difference of risk? Both of those are risky things, and both of those are things you would only do if you were highly suspicious of a diagnosis of TTP. And I think you see that reflected in the ISTH guidelines. Is you need to have that confirmation of the ADAMTS13 activity, which you might not get for 1, 2, or 3 days. But if you're suspicious enough to do plasma exchange, I think it's reasonable to start caplacizumab. Your response in terms of the caplacizumab and the plasma exchange will kind of give you a clue that you're on the right path. And if your thrombocytopenia and TMA is driven by microthrombotic disease, you'll see a marked response and you'll know you're on the right path. But at the same point, for a while, my institution would wait until outpatient approval was obtained for the caplacizumab. So what the end result was, I got about a 2-day delay in starting, or a 3-day delay. And do I think that's a problem? No, I think it goes down to what's the real role of caplacizumab. It's not a quicker platelet count, but it's blocking refractory disease, and the real benefit are these exacerbations. So if you don't get it for 2 or 3 days, but you get it before you stop plasma exchange, I think that's perfectly reasonable. I think the mark's been missed on what's the real benefit of this drug, and it's really blocking. And if you're old like me and you've done this for a long time, there's nothing worse than seeing a patient 2 weeks after the hospital visit. We used to see them weekly for the first 4 weeks because of this risk. To see them come in and have to go tell them your platelet count is 70,000, your LDH is 320, and that abdominal pain you're having is a recurrence of your TTP. That's just something we just don't have to do anymore, which is quite nice. So if there's a delay in starting it, this is a long answer. I'm sorry. If there's a delay in starting it, I think you're still getting the benefit of blocking those exacerbations.
I agree with you. I think that's the main benefit with this drug is the exacerbations, which, we do see quite a bit. Now you mentioned you wait for outpatient approval. What's your experience and how often that's occurred?
Because it's FDA approved, it's always really given. I think that a lot of things in life come down to money. And the problem with the inpatient dosing is hospitals end up eating the inpatient dosing price, and the outpatient is almost always covered. And if not covered, the company will provide drug. So I think that's really the rub. Hospitals don't like giving that extra expense, and they don't want to give it unless it's absolutely required. So that's really kind of where the rubber hits the road. And I get that. I mean, I tell people the main truth about caplacizumab that I can tell you, it's very effective and it's very expensive. There's no way around both those ideas, I don't think. Um, but it's really paradigm changing, sort of how you deal. Like you said, Reed, these exacerbations are a problem. Telling them they're going back to the hospital for another central line, it's just a rough thing for a patient to deal with.
No, thank you for that. I just had one more question.
Sure.
What's your experience with second or third generation anti-CD20 monoclonal antibodies in TTP like obinutuzumab or
Yeah,
ofatumumab?
more limited. I've had a few cases of sort of a serum sickness with rituximab, so I've had some obinutuzumab experience that way. My colleague in London, Marie Scully, uses it a fair bit. I think she's pretty comfortable with it. So I don't think my concern at whether it's a generic biologic, I think it's fine. I think as long as you're getting that anti-CD20 approach, I think it's reasonable. Yeah. Actually, real quick, Robert, you raised a great question about the line placement in the Capla. There's a lot of push for early Capla, but be very careful. As you were saying, if you give a dose of Capla and you go to put in a central line, you got to be careful what's going on. You might lead to a bleeding complication.
Thank you.
Does anyone has any other questions?
Yeah, Dr. Cataland, this is Yumin Chen, one of the other hematologists. I was wondering if you have any experience in using daratumumab as opposed to rituximab in CPP.
You said daratumumab?
Yes.
Yeah, not as much. We've tried in a couple more refractory cases, and the difficulty is once you get past rituximab and cyclosporin, which we've used, you get into agents that have more toxicity potentially, and I think that includes daratumumab. I've There are some reports of it being effective. It kind of makes sense, targeting more of the plasma cells. It might be more effective. Um, but I don't have a great deal of experience with that. There's certainly published reports and the rationale for what might be effective. I think what you're going to see very soon is as the disease treatment up front gets simplified with caplacizumab or rituximab or recombinant TS13, the upfront treatment is going to be more straightforward, won't involve plasma, and we're going to see our better studies of immune suppressive therapy that aren't going to be confounded by a plasma exchange, that we're actually going to be able to do a rational approach to knowing what works. I think daratumumab is something that's very interesting, but there's a lot of things being considered and talked about, which makes sense, including splenectomy out there still.
Okay. Well, thank you so much.
Sure, thank you. Good question.
Okay. Thank you, Dr. Cataland. This was a phenomenal talk today, and I hope everyone enjoyed. And if you have any question to Dr. Cataland, please reach out to me or reach out to him directly.
Yeah, let me know. Happy to help. Thanks for the invitation, Taha. I really appreciate it.
Have a wonderful
Great meeting.
day and weekend.